Good afternoon, everyone. First of all, thank you very much for staying to the final session. And this is very exciting. We are absolutely delighted to welcome two very important people to share the stage on our final session. I'd like to introduce them both at the moment, and then they'll take the podium one after the other to give each short presentations, and then I will just summarise briefly on behalf of Physio First, and then we'll move straight to questions. So first of all, I don't think she needs very much introduction, but in case you haven't come across Natalie on the last couple of days, we welcome Natalie Beswetherick, who is the Director of Practice and Development at the Charter Society of Physiotherapy. And her directorate provides expert advice and services to members and external stakeholders covering the breadth of practice of the profession, including research, education and clinical practice. It's quite a long time since we had such an eminent member of the CSP to speak in a session, so thank you very much for coming, and we've enjoyed having you with us, Natalie. And then, I think Greg probably does need a little more introduction to some of you, but Greg Swarbrick, thank you very much for coming on a Saturday afternoon to share our conference with Physio First. Greg leads the development and use of quality data across Bupa's UK various provider and insurance businesses, Head of Healthcare Outcomes at Bupa. His current work includes developing a quality framework for musculoskeletal conditions in all care settings. So first of all, I'd like to welcome Natalie.
Thank you very much, Pam, and thanks to Physio First for inviting me to the conference. I haven't been to a Physio First conference since I was actually chair of CSP Council, and that is donkeys years ago. So it is great to be here, and it's great to see what a real vibrant network you really are driving forward, and in a very different place to all those years ago, I think. So it's been incredible to see the changes, not just in the exhibition, but the things you're working on. And I know Pam will be going through about the quality assurance stuff that you're really actually are getting involved in collecting data. I'm going to be talking about sort of outcome measures, and I just wanted to start off. Can everybody put their hand up if you're using outcome measures? Well, I think I might just sit down then. How many of you know colleagues that don't? Okay. And how many people do you know, if you've had a conversation, I had a conversation with somebody earlier on, that they've made up their own outcome measures? Breakfast. Right, so I'm going to quickly go through, what our position is and why they are really critical to practice. I mean, you will know that outcomes have become the currency of modern healthcare. Patient-related and patient-reported outcome measures, PROMs, and experience measures are key to demonstrating the success of physiotherapy in your interventions. Using standardised, validated outcome measures in clinical practice is an explicit requirement of the CSP's quality assurance standards for members. You all know that improving the quality of healthcare is top of the agenda across the UK, and it is resulting in a massively increased focus on methods of measuring the quality of clinical practice and service delivery. I'm going to quickly talk through about why PROMs and PREMs, and then actually think about where next. The patient-reported outcome measures were introduced into the NHS in England in 2009, and they marked a significant change in emphasis in terms of care and the outcome for people. There was a real desire to measure the impact of healthcare interventions from a patient's perspective rather than historically from the therapist's perspective. So it's a real big sea change. And since 2010, when the white paper, what's it called, Liberating something or other, sounds about early for Brexit, isn't it? Liberating the NHS, it was called. You'll probably have that, firmly in your mind. But then it resulted in that massive, the biggest change since then, 2012, which was the change into the Health and Social Care Act. And since then, commissioners and planners, depending on which country you're in, and service plans, they've increasingly included PROMs, patient-reported, not just outcome measures, but experience measures, in their specifications, in contracts, and they've become a routine element, I think, in clinical governance and service redesign. The other reason why collecting outcomes is absolutely critical for all practitioners is because it's demanded through the regulator, the HCPC. Standard 12, slips off the tongue, standards of proficiency for physiotherapists. It says that all registrant physiotherapists must be able to assure the quality of their practice. And that includes the collection of data to demonstrate the outcomes that you've actually delivered in terms of all your interventions. It is really important stuff. So both PROMs and PREMs play a vital role in enabling physiotherapy services to demonstrate their effectiveness, their cost effectiveness, and their impact on healthcare. There's quite a few examples of PROMs that you'll be familiar with. The first one is the EQ5D that quite a few people do use, not just in MSK practice, but right across practice. It's a generic patient-reported outcome measure and quality of life. It was developed in Netherlands by Euroqual, and it is applicable for almost all conditions, so long as the patient is able to actually report. So they aren't applicable to children, and they're not really used in mental health where people are unable to make a judgment. Many of you will be aware it's a simple measure which patients complete at the beginning before their first treatments and at the end. It's got 5 dimensions. That's why it used to be called EQ5D, and 5L at the end of it. 5 levels, including health, mobility, ability to self-care, ability to undertake ordinary usual activities, pain and discomfort, anxiety and depression. There are some disease-specific PROMs that you may be familiar with. The most recent one that I'm aware of is the one that was developed by Arthritis Research UK with Keele and Oxford universities, and it's called the MSK-HQ Health Questionnaire. That is available if you're actually working in the NHS for free, but if you are working in commercial areas, you have to actually apply for license to Oxford, and I have got the details if anybody wants that later. Again, it's a very short questionnaire that allows people with MSK conditions to report their symptoms and quality of life in a standardised way. It focuses on aspects of health and not specific diseases, and this one covers pain, mood, dexterity, self-efficacy, fatigue, and mobility. So you can see there's actually quite a similarity between the two, but one is very much MSK focused, and the other one is for almost everything else. There are obviously a range of PREMs as well, and these are there can be 2 types of patient questionnaire, normally either functional and relational. The functional questionnaires normally ask the patient about practical issues like, could you park your car? With the nice magazines in the waiting room, and how long did you wait? And then relational questionnaires ask the patient about the experience of the treatment relationship that they had. For example, did they feel that they were listened to? Did they feel that the therapist understood them? And did they take part in decision making? So there are quite, 2 different types, but the most important one is that relational questionnaire. And the CSP recommends the PREM called CARE, which is the Consultation and Relational Empathy measure. But other PREMs are also available. So the most important thing for you to do, wherever you're practicing, whether you're in a group practice or on your own, is to collect outcome measures. There are loads of people, whether you're working, delivering NHS contracts or actually in the independent sector, people are using these all the time, and I was interested. I went to a launch by Connect Healthcare of their new, it's called Board Governance Advice. And within their contracts, which they obviously supply to the NHS, they use both EQ5D and the MSK HQ, and they're actually saying to commissioners as well as providers, those should be a minimum that you should be collating. So I think it's really interesting that some of the big providers of NHS services are, in the independent sector, actually are using these as the norm. So the one key message I would ask you to go away with is if you're not using something, do, and make sure it's standardised, and make sure it's something that's been ratified and is robust. It is no good you making up your own, because that's not going to help, because you can't then be compared with anybody else. So look to what has been measured, tested out, and you won't go far wrong. So happy hunting, and all this information is on the CSP website. Thank you very much.
Good afternoon, everyone. Thank you very much for inviting me here today, Pam, Physio First, and everyone. It's a pleasure to be here. So I'm Greg Swarbrick. I'm Head of Healthcare Outcomes at Bupa UK. I recognised last week that having been in the job for 5 years that my acronym was HO-HO, which was... there we go. It's just one of those things. We were talking about acronyms of different people, and I thought I didn't want to be an acronym until I realised what I was. So in terms of being Head of Healthcare Outcomes at Bupa UK, what that means is that I work with all of our different businesses, both provider and insurer businesses. So that includes our care homes, our dental practices, our health clinics, our hospital, Cromwell Hospital, as well as the insurance business, to really understand what are the right, most appropriate measures of quality. How do we collect those? How do we record the data? And how do we really use that to improve patient care, which is what it's all about. So very wide range. I'm a generalist. I'm not a specialist. And really, I'm going to sort of talk a little bit about why I'm here today. So 3 years ago, I was asked by our insurance business, so really the commercial people, I'm not commercial, to advise them on what the right measures of quality should be when renewing the outpatient MSK Physio network. And I'll talk about that through the course of this journey. And the reason that they wanted my advice was that a frustration, I'm sure, shared by many, is that you have one very, very simple measure of quality, so to speak, which is the number of treatment sessions, which really isn't very satisfactory. And we wanted to move on beyond that, because it's what our patients want. Most of all, we understand that the number of sessions causes frustrations for the practitioners as well. As an insurer, we also want to make sure that we're getting value for money, that we're getting the right outcomes. So that was definitely a challenge. So in terms of the what do I mean by outcomes? This is the Bupa view. What I've been sort of developing over the last few years in terms of what we mean by outcomes. And as I just said, number of sessions. In this trivial pursuit model, you've got a blue segment which represents efficiency. So in this context, and this refers to all of the contexts of healthcare that Bupa is involved in, you've got efficiency here, number of sessions, but in hospital it might be number of nights stay and so on. But that's very, very crude as a measure of quality. So what we have are different measures of quality, the outcome measures, which collectively, and that's the really important point, you can't say what is quality just looking at one particular measure. It's just not enough. You can't say that 5-night stay is right for a patient in hospital. For some it might be 3, it might be right to have 6 for other patients. And sometimes these different segments, they're conflicting with each other. So I had a problem with the boiler on Wednesday. We had 2 people come along. The first one was very rude, and he messed it up even more. The second one, really nice guy, and he fixed all of the problems, and I was very happy. But from a customer's point of view, I was thinking, well, we're paying the same amount to both of them, and that's not good. So how can we move on to really represent the quality, the full rounded quality of what we're commissioning here as an insurer and what we're delivering here as a provider? So you've got patient satisfaction, another positive, health impact, the most challenging of all, the PROMs, because trying to get follow-on PROMs responses is a massive challenge. I've seen that within patients as it's been implemented with the private healthcare information network. We're talking rates of 5–10%. It's not good. And that's because the patients don't always understand it. They're not always guided towards that by the clinicians as something that just is part of the clinical pathway. But it needs to be. They need to appreciate how important it is to have this data. So you want health impact, you want patient satisfaction, you want efficiency as a collective measures of outcome, and particularly in inpatient contexts and for day surgery as well, you want to collect the things that may happen that might be outside your control, like the clinical incidents, mortality and so on, the complaints which you're going to get whether you like it or not. That's the flip side of patient satisfaction, and safety, the sorts of measures that should be prevented. And for these slides, very happy to share these afterwards. I realise there's quite a lot of information on the screen. So on the next slide, like I said, this is quite a bit of information. I've talked about what are outcomes, now about why quality and outcomes are important. And I've divided it into three columns. Because it's good for patients, it really helps them understand what they're hoping to get in terms of getting better, what that looks like in terms of improvement for pain, function, quality of life. It's good for clinicians to understand how well they're doing and areas to improve on. And from a commissioner's point of view, and this is for Bupa, this is a slide I've been working on for the last year or so, as a provider as well as an insurer, it's really good from an insurer's commissioner's point of view of making sure that you're getting the right quality that you're hoping to deliver for your customers. So obviously more detail here on the slide itself, but and there are overlapping interests here as well. But this is good for all of us to have quality measures. We want it. Now the tricky bit is how to get all that information, and that's the challenge. But I hope, I really want to impress on probably an audience that you're aware of this already. How do we make sure that this is collected and used to improve healthcare, which is what we want? So I'll come back to my little journey here. So I was asked to identify what would be good quality measures for private healthcare. And I thought, well, what I can't be doing is telling people these are the measures and that's that. That would be wrong. So started having a number of conversations with different organisations. So Pam and Paul from Physio First. We ended up having conversations with a whole range of providers, and I had a sense we're repeating the same conversations. We're all really interested in this, but we're all like little islands speaking slightly different languages. It became clear that some organisations are not collecting any quality data whatsoever. Other organisations are collecting some standardised measures, but there was a complete fragmentation in terms of what's being used, and that doesn't enable standardisation and comparison. So we got together a working group of these organisations, and it's always been very open, always happy to have more people at the table, more views, and having providers and insurers and professional bodies sitting in the same room, listening to each other, hearing what was good for one organisation or frustrations with another organisation in terms of quality. We very, very quickly actually got to a really positive vibe, for want of a better word. We were listening to each other and being able to understand each other's points of view. And quite quickly, we found points of common interest, because obviously quality is important to all of us. So even if new members came to that group and it was sometimes a bit fluid, very quickly there was a sense of this works for all of us. And we are not in any way saying that this is a perfect model, but it's good enough for us right now to start off with. So we had this working group, we listened to each other's points of view, and what we ended up with was a set of recommended measures and also a sequence to get us from complete fragmentation in private healthcare in terms of the measurement of quality to standardization. Now, obviously, that doesn't happen in one step. It will take what we've worked out as being 3 steps to get there. We're not at this stage mandating particular measures because we just don't know what everyone else is using. But the important starting point is that everyone is collecting measures of quality. That's the bottom line. And this type of thing is certainly influencing Bupa from the commissioning perspective. We want to be able to work with organisations that are demonstrating an interest and a commitment to the recording of quality. That's the first step. Once we know what everyone's using and what the pros and cons of different measures are, we will be in a better position to work out collectively, providers and insurers and professional bodies, what would be sensible and would work for all in terms of standardized measures. So we're not there yet, but we need to be collecting this data. And we're really impressed with Physio First, QAP and QA C schemes in terms that they fit the model very well. And this model, there are things that are incomplete about it. It would be really nice to know about return to work, but we couldn't get that agreed by all of the working groups, so we've just left it out for the time being, but it would be nice to have that later on. So it's a starting point. And as I said, in terms of direction of travel, we are incorporating this into our commissioning increasingly. I guess the important point from a commissioner's point of view also is that we don't want to be commissioning blindly. We do want to trust more and more and more. And in fact, where we're moving to in the last 6 months or so is setting up working with clinical groups who, once they show that they have got all the right measures in place in their area, they've got the right processes, we're devolving more and more responsibility to them. And that seems to be working very well. It's about 10 or 12 groups we've approved so far, but we definitely see that as the direction of travel, that we as a commissioner shouldn't be holding so much, that we should be devolving more and more trust, more and more responsibility, authority. You know the patient's best, but we can't just trust blindly or pay a check blindly. We need to have, I think it was Ronald Reagan was saying something along the lines of, you need to trust and verify at the same time. And it's an interesting balance, but we do need data, because otherwise we would be completely in the dark, and we don't want to be there. So as we start to have quality data, I look after the Bupa clinics, which is we have physiotherapy, GP services, various musculoskeletal dermatology. Now that we're starting to collect data in exactly these formats that I've been talking about, it's fantastic because you can start answering questions around, what's the right length of stay for a particular initial, condition that the patient has. And we can see that different patients, different types of condition need different things. And that's the right level of detail we want to be getting into. But again, it's data that gets us there. And obviously that's very important for managing the patient's expectations and also for the clinicians as well. So my last slide is, I guess, just a bit of a caveat, but also hopefully a positive one as well. Where we're moving to in this whole thing about data is that data is great, but people are more important. And I say that from the point of view of seeing lots of data recently, for example, looking at our GPs and finding one person who's prescribing to 49% of his patients, another person to 13%. Thinking, why is there the difference? And it's easy to rush to some sorts of conclusions, and that is precisely the wrong thing to do. The way I see outcomes is that outcomes and the data is a starting point to ask questions. Because as I've asked questions about the prescribing, this GP is working in a very particular environment where the customers are extremely demanding and expect to get medication so that they can be at work at 9 o'clock every morning. So actually the data can be really, really supportive to be able to push back and say, to this particular organisation, do you know what you're doing to your staff? In another context, where we have a triage phone call service, we have, incredibly high numbers of phone calls when actually one is what you're supposed to be having. So 22 phone calls, what's happening in terms of speaking with the same patient again and again, and they're not necessarily getting better. In fact, in mental health, dozens and dozens of sessions without any evidence that it's being effective at all. So we do need to look at the data, to use that data as a starting point to ask questions, not to rush to judgment. And with that, there's a better understanding of what's right and what's appropriate, and sometimes that there are certainly interventions which are not appropriate, or it's important to have some processes in place to say we need to stop here and check that things are working, and then to move on. So in terms of supporting staff, we need to be able to talk about outcomes, to say why we're collecting them, what they are, what we're doing with the data, also what we're not doing with the data. So I guess as an end point, I'm really keen that the whole point of outcomes is to support our staff, support all providers to be able to deliver the best quality care possible, to be able to help our customers get the best care possible for them. We need to do it carefully. We need to move step by step, learn as we go through this process. But it's exactly the right thing. It's what our customers are asking for from us. Thank you.
Okay, so thanks to both Natalie and to Greg for their viewpoints on data collection, and those of you who have been Physio First members a long time and been coming to conference a long time know that we as an organisation started collecting data some 12, I think almost 15 years ago now. And we have an exponential rise in our numbers of discharged patient data sets on our current tool, which is surpassing now probably 50,000 patients, which is a massive amount of data, which we're now able to explore. So data collection, if you just want to collect data on a validated, standardized data collection tool, and you're not collecting data already, then Data for Impact will do just that. So that's your validated tool that does all the things that Natalie was talking about and all the things that Greg was talking about. Within our Data for Impact tool, there is elements of both a prem and also the diagnostic coding. So that's embedded in that tool. And I know that a lot of you have signed up to that, and a lot of you are regularly inputting your data, which is great. But data collection doesn't necessarily mean quality, does it? They are quality measures, but unless you analyse that data, how do you decide from just a set of numbers what determines quality? So for the MSK working group, that will be, that Greg just described, that will be one of their next challenges. And as you know, that was the challenge we started when we first launched QAP, and now when we've launched QAC. So, you know that quality assured practitioner status is a Physio First member who has inputted sufficient discharge patients into the system, which is then considered by the University of Brighton, anonymous of Physio First. We don't know who you are, and your data analysed against the baseline criteria. And then the award of QAP is given to you, and you out yourselves to Physio First. And then you become a Physio First quality assured practitioner for 12 months, and you continue to input your data and you're remeasured. I'm sure I'm telling you something now, I hope I'm telling you something now, which is becoming extremely familiar. Quality assured clinic, yes, is new, and that's when all MSK clinicians within a practice, and of course part-time subscribing helps all of your clinicians to become members to do it, where the clinic data is considered as a whole against those baseline markers and clinic status awarded. Now, of course, those markers were not just picked out of the blue. The tool itself has 23 questions, and I'm sure that you could probably tell me what all those 23 questions are. So which bit of that was quality? And how was that determined? Well, that was determined by focus group, by Physio First executive, by the researchers at the University of Brighton, with the help of Professor Anne Moore, who was involved with us for a very long time. So we looked at what markers formed quality. And before I come on to them, we also needed another external validation for our data. The standardised data collection tool is and of itself is not a validated standalone PROM. There's elements within it, of course, that are a PROM, but they are filled in usually with a combination of the clinician and the patient. Now, a true patient-reported outcome measure, a true PROM, can be filled in completely independent of the clinician. So we recommend it currently, and all the PROMs that Natalie suggested, EQ5D, MSKHQ, and so on, we at the moment recommend the validated B-PROM, which is sent to the patient prior to the treatment and then again at the end of the treatment. That's can be done in paper form or electronic, but where it's sent in electronically, that goes to the same university server, is filled in by the patient independently, goes to the same server and is matched against your data for impact data, which means that the patient alone is independently verifying the data that you have inputted. That is a complete validation and a complete defense against anybody who says, well, you could just fill it in. So that's a huge step forward, and we're hoping that that will grow. So those 5 markers. How did we decide which bits to lift out of your data and determine quality? And actually, they're quite sensible when you really think about it. Which bits does that patient value as being part of QAC or QAP? So, does the patient achieve the goal that's set at the beginning of their treatment episode? What's the outcome of the referral? Is it successful and agreed discharge? How many treatments did it take? And yes, that's one marker as part of the baseline. Because, of course, cost-effective efficiency is something that we all have to be interested in. What's the change in their FBS scores from the beginning when they first come for their treatment and at the time of discharge? And how does that fit with their achievement of their goal? And what time does the patient wait until their first appointment? Now, I am not an academic. I've never professed to be an academic. And the university have looked long and hard at how they would form baseline data from the data inputted to decide how to form the equation around the measurement of those 5 markers. But remember, you do only need to achieve each time 3 out of those 5 markers, which allows for some differences in our clinics. So maybe somewhere you have very complex patients, regular patients from the same consultant who all have post-op patients with a complex condition. So actually your number of treatments might be fairly high compared with the baseline data. But that would be that would be not one of the 3 that would count for you. And what about somebody who works maybe part-time or who has a very, very busy clinic and actually people really want to see you and they're prepared to wait? And they're prepared to wait 2 weeks, 3 weeks just to see you. Well, you shouldn't be penalised, should you? So no, you're not. Because that time between the ring up and the appointment and the time they start their treatment might fall short of the baseline. But that would not be one of your 3 counters. So there is variation and allows for the differences, vast differences, in the sort of clinics that we all have. So what does our data say? There were some of you that were at the AGM yesterday, and you will have heard these evidence statements then. So we know. Our data, 50,000, well, actually, these strap lines were taken from 38,985 or something, discharged patients' data sets. But 9 out of 10 patients who see a private practitioner, Physio First private practitioner, are seen within 1 week. That's phenomenal. 77% of our patients exceed or fully or significantly achieve their treatment goals. Now you'll see there's little link, what are they called, icons on there. These screenshots are taken from our new e-booklet, which is on the website. You'll find it from the homepage. If you click on the link icon, you will find behind there a significant amount of robust evidence to defend these statements. And thinking about the topic for our conference and all the evidence we've heard over the last 2 days, it is demonstrable that our clinicians who input data, that our data shows that it was 36,858. 90.5%, so 90% of all the patients we treat with at least 3 treatment modalities. So what that tells us is that our treatments are neither hands-on nor hands-off, that our treatments are person-centred by and large, because 90% of our clinicians choose the modalities for that patient at that time. So this is powerful evidence that we can use in defence and to promote private practitioners who are evidence-based. I also said yesterday, and I quoted, but he denied the quote on a Twitter later on, that it is a popular saying now, that's all I can say, is that if you don't count, you will not count. So back to a lot of the grumble. It's very difficult to shout about quality without evidence. And until you and we can evidence that quality, there can be no reward. Thank you.
Shouldn't the CSP support us as physio, i.e. physical therapy, and not allow authorities to stop us from doing manual therapy?
A really interesting question, and will be probably from probably a local commissioner decision, I presume, rather than anything else, because the CSP has not stopped anybody doing anything. Half the time we get asked to say, can we stop everybody using electrotherapy? That's not one I get quite regularly. So it's interesting, and it maybe whether it's because of that fashion versus the evidence base that people seek to stop doing things. But I'm not aware where this is happening, and we would want to, if we knew if this was a particular area, so this is a particular decision that's been made, we would want to be aware of it so we can actually raise it with the relevant commissioners. So if you know that there is an area where this is happening, come and talk to me.
Certainly from a Bupa perspective, I don't know the specifics of this treatment, but what happens from an insurance view is that we have a range of medical directors, and we very regularly get questions from across the whole of the sort of the healthcare environment about can you approve this treatment? This has worked really well for me. Can you approve it for someone else? We are regularly being asked, and obviously, I guess the answer is if there's published medical evidence to suggest that it is an effective treatment, then we will always trial it, and more important than anything else, getting the evidence that it actually works. So we're always open-minded about it with medical guidance.
Thank you very much. And the next question that's been flagged up really is, should we be addressing the training of physiotherapists to include more hands-on, despite the NHS placements not in reinforcing this?
In terms of what the HEIs are teaching, we review every single curricula of new courses and existing registrationable courses across the UK. I'm going to be taking away, because I've heard it quite a few times over the weekend, that there seems to be a move in certain universities about doing far less in terms of even sort of like touch, in terms of palpation assessment, heaven help actually techniques beyond that in terms of manual therapy. So I'll take that away to actually raise that with our team, because we do actually go to the universities and speak with students, you know, the lecturers, everybody. And that team that go out are also lecturers from other universities that will do a deep dive into what's happening. So I am somewhat surprised if this is going on. I'm not dissing the actual your experience of what people are saying to you, but we do need to unpick this, because it has been a part of our profession since certainly the Royal Charter, as Tim says, since 100 years ago, which is next year. So again, I will actually take that back, because I think we do need to be really looking in detail about what people are perhaps actually not covering in the curricula for the actual qualifying programmes now.
Great, thank you very much. There's a question that's come in regarding Bupa, so I'll hand the mic, or please feel free to pick up the mic. If there is standardisation of quality outcomes required by Bupa from its physio providers, surely there should be standardisation of physio fees paid by Bupa? Tricky one.
Tricky one, yeah. Good question.
That was bold. Would you like to stand up?
I mean, I haven't got a crystal ball, obviously. And I've probably made the point, hopefully, that we are on a journey here. We don't have standardisation of measures yet, but we definitely want to work towards having standardisation of measures. We recognise, obviously, that patients are different. And we want to be able to provide, you know, to pay fairly, if that makes sense, to say it very, very simply. And we do review complexity, we review the amount of work that goes in, we want to be able to review the outputs that come from that. Like I said right at the beginning, I'm not the commercial person, so I can't answer that any better, but hopefully with the advent of standardised outcome measurement, we can pay much more fairly, and I think that's what probably everyone wants to get to.
Yes.
Yeah.
No, that was well answered. Could seeing people with persistent pain every 6 to 8 weeks for progression of exercises, activities, advice be beneficial to support them through self-management?
I don't know, but it is a question I'd love to know the answer to, if anybody has any evidence.
I'm a patient at the moment, and I'm following the Escape Pain programme, and my physiotherapist asked me about what is it that I wanted from her, and we agreed that that's what I'll do, is I'll have a check-in point at a point that I thought was going to be beneficial, so she can ask me about how I'm going on with my self-management and how that's going. And so I'm going to be, I've agreed with her that I'm going to give her we're going to have a telephone consult in 3 months' time. So I think this is about what is the best for the patient in front of you. You've heard that the whole weekend. That's the most important thing. So I think if that's what the person wants, and it's about shared decision making, then you know I think that's what's wrong with that.
Thank you very much. And it'd be interesting to get your direct feedback, actually, having gone through that process as well. Somebody has just actually asked, can we have a vote on how many people have heard from a patient that they've not been touched or undressed for an examination within an NHS physio?
Yeah, I know it's anecdotal, and I know it's just one person. My mother-in-law is 85. She's had back pain for 2 years, 3 years, and it's stopping her walking. She's eventually got her GP to refer her to physio, and that referral is going to consist of 1 15-minute telephone consultation. So she's not going to get touched because it's a phone conversation. They will then decide on what the appropriate exercise program is going to be, and they're going to email it to her. She is 80 blinking 5. how is she going to download a PDF attached to an email and then do what those... I mean, it may be a bad example. It may be a completely off the wall. I don't think it is completely off the wall. And we're not doing ourselves any favour. I know there's constraints on the system, but in terms of the show of hands, it tells a story. How is that portraying physio in a positive or a good light? And the downside, and it's a conversation I had outside, and it may not be the conversation I'm supposed to be talking about here, the downside is that physio as a profession will get labelled with that kind of stuff, and therefore when the patient... I think I want Jeremy Vine. Woo! When the patient then says, blow this for a bunch of cherries, I'm going to have to spend some money and go and get some proper help, they are then going to be less likely to arrive on your doorstep because you're going to get labelled with what they've just received, which is pants. And that's not fair, but that's what's going to happen. And if I was in your position, that's what I would worry about.
I just wanted to make a comment because it's interesting. I'm aware of certainly the big corporates, the big three, Ascenti, HealthShare and Connect Health. All three of them, and they're right over the country, some more in the south, some more in the north and east and all the rest of it. Their business models are based on a telephone consult first. And so a lot of people never get past that telephone consultation. And I have visited some services where they do then get sent from somewhere else in the country, from their, I don't know whether it's their hub or whatever, the exercise thing that comes through the post. So that is a commissioned model by your local commissioners. And that's where, we are, the CSP will highlight these, this is, deleterious to the patient as well as actually to other people when we know about them. But they're doing that because the local commissioners are doing it on money. And they are winning the tenders away from the services that would see people face to face, because that's going to be a much cheaper model of care. The only bit of, I think, on the horizon, a bit of sunshine, possibly, is this government, apart from Brexit, is actually looking to repeal quite a few elements of the Health and Social Care Act. And one of the big elements they're looking at is actually removing mandation of procurement for community services. And I think that, so you might see a sea change then. But that was brought in with that Health and Social Care Act of 2012. So and where those services are going out, they are being replaced. Now for some people, I have a telephone consult with my GP, and that's fine because that's what I've wanted. But I think what you've got is that patients aren't being given the choice. It's actually, this is the only thing that's actually available to you. And you've got to go through quite a few hoops. So I can understand what you're saying. And the CSP will raise those issues in those areas where we're made aware earlier on that that can have been, it's going to be not to the benefit of patients in that population. And we know there are, at the moment, there's some really big complaints going on in some of the services where this has happened. And the complaint levels are absolutely, through the ceiling because people have started taking action. So I think, we will be working with those places to actually say that this is actually not good for people.
I work in the world of medical negligence and hear physios saying that they're frightened of being sued, so they prefer not to touch patients. Anyone like to make a comment?
Yeah, I will. Part of my role is actually to review all the clinical negligence cases that come in to the CSP. And I've reviewed 15 years of data. And touching is nothing to do, it's never, ever been an issue. Not ever, 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 ever. But what is harm from other things. But the types of cases that we see are still really small for the size of the body that is physiotherapy. So, yes, there were cases of misdiagnosis, and that included, and it's interesting, isn't it, because 20-odd years ago, we wouldn't be talking about misdiagnosis because physios weren't really doing it. So nowadays, misdiagnosis is actually quite one of the bigger ones, and that could be anything from really rare conditions to CES to whatever. The other ones that are small but significant are burns. Burns from electrotherapy. This is people just not applying it properly. And some of them are full degree burns. honestly, you know, I always get a sharp intake of breath when I say that, but that's what people are doing. Mostly with interferential, from the pads, wheat bags. I don't know what they're doing with the wheat bags, but to give somebody a burn from them, heaven only knows what they were doing. And from shortwave and other things. We have had pneumothoraces from acupuncture needle in the right apex. But, you know, that doesn't do any long-lasting harm anyway. I mean, it sounds dreadful, and obviously is distressing for the individual, but it can quickly be sorted out, and they heal up really fast. So there are some, but this one is not one of them at all, not ever. And people, I don't know why people are so worried. And I think it's really interesting. The other thing I found just by interest is even though that the physiotherapy profession, including Physio First's makeup, is majority women, you're more likely to get a claim against you if you're male. Okay, so I've got loads of information on that if you want me to have any more information, but that is not one that people actually ever say anything about. There's no evidence of that at all.